Right. Good morning and welcome everyone to our August 13th Buzz session for PC 730. I'm looking forward to talking with you guys about your projects. This is such an exciting time as we're really figuring out what the projects are going to be like and how the ramps are going to work. It's really the most exciting time, I think, in the whole thing, because you have this opportunity right now to really get it right. So I'm looking forward to talking about it. So what I'd like to start off with is just a quick introduction. If you'll just say who you are and what your project is, something quick about it, where you are, that kind of thing. And then we'll go through and kind of share our gaps in patient tracers and how we knew what our problem was and how we're going to fix it, kind of stuff. Kelly, why don't you start?
I can start. I'm Kelly Papish, and I am doing my project on a better screening tool for depression in patients with Parkinson's disease.
Cool. And where are you?
I'm in Las Vegas.
Awesome. I'm just writing some notes. Okay. And then Sam, why don't you go next?
Sorry guys, I'm in Amarillo right now on a family emergency, so my internet's a little weird.
Oh no.
It's okay. So if it cuts out, let me know and I'll go back and come back in. So I'm Samantha Gallegos-Gollihue. I'm a certified nurse midwife, and I live in Santa Fe, but I work in Albuquerque. And I am working on improving breastfeeding rates amongst neonatal abstinence families. So trying to find women on opiate replacement therapy who are on good maintenance and increasing the rate of breastfeeding in our facility.
Very cool. All right, Sheena, you're up.
Hi, this is Sheena, and I live and work in south central Missouri, very rural. And my project is antibiotic stewardship in the outpatient setting, so decreasing the amount of antibiotics that are used unnecessarily for things like acute bronchitis and upper respiratory infections and otitis media, stuff like that. So.
Awesome. You guys have some very interesting projects. So when we very first start out the program, the way we ask you to choose a project is to think about the site where you're at, right? Think about what's going on there. What kind of gaps in practice have you seen? And then we start having you do assignments to explore those gaps a little bit more. So would somebody like to share their gap in patient tracer? Actually, what I'd like you to do is kind of share whatever information it takes. So whatever it is that you think really led you to the place where your ramps are, if you want to show us like your gap, your patient tracer, or whatever it was that you feel like really led you to that place.
I guess I can go. Do you want me to show on the screen, or do I just have them open for me to talk about?
If you've got a diagram or something like that you want to share, then sharing is great. It's kind of up to you, since every one of these assignments ends up so different that I can't, for each project, different things will kind of be the more important. So you just present it however you want to.
Okay. So basically, and I guess I don't know how to share. So if you want me to share them, let me know.
Sure. Yeah. So on the top left, there's a green button that says screen share. It doesn't show up until you hover over it.
Okay. Okay.
Yeah, awesome.
Can you guys see my screen?
Yes, and if you click on Kelly's name, you'll be able to keep it large.
So part of my patient tracer, so I guess for this project, I decided to look at the screening that was utilized currently in our clinic. I work for the Cleveland Clinic, and it's a subacute specialty facility for movement disorders, and I work in Parkinson's and Huntington's disease patients. And it's about close to 60% of these patients have depression. About 22% on average are diagnosed with depression. What we do currently in our system is that we have this program in Epic called the Knowledge Program. It's Epic is our online, and that is where patients go on before they come into the visit, and they pre-assessment. And as you can imagine, the Parkinson's population is a little bit elderly. It's often 60 or older, but we have a lot of elderly patients in their 80s or higher, and a lot of them do not fill out this pre-assessment. And one thing that's included in the pre-assessment is the PHQ-9. So when patients come into the clinic, we definitely address mood. We ask them how they're doing. But if we don't have the pre-assessment filled out, then what we've found is that we actually have no formal standardized assessment that's given to these patients. So my goal is to get 100% of my patients with a formal screening. And if I show you my, oh gosh, what is it called? Yes, the gap analysis. I'm going to try to have 100% of the patients with a documented PHQ-9 in their chart. One of the ways that I want to do it is to give a standardized form and present a handout, just a hard copy during their pre-assessment with the medical assistant. And that would allow for all of our patients to be screened, and therefore hopefully finding the of completion, and therefore addressing depression and Parkinson's more frequently. I don't know what you need to see on these sheets. Sorry. Chart audit. Oh, I thought I had it open. I'm so sorry, you guys. So on my chart audit charts, and as you can see, I did a standardized assessment tool with our online portal, and out of the 20 charts, 4 had completed that. Is that right? Okay. That's right. So for the focused depression on assessment, that was if it was completely addressed in the chart, documented within the provider's chart notes at somewhere along the chart. And then, let's see.
Those focused depression, the focused depression assessment, so those 10, so that's like 50% of the charts that had it. Does that include the 4 that that had the standardized assessment?
Yeah, I believe it does.
Okay.
And if you look at chart number 18, they also had the focus. So I think what happens with the online portal, if they screen for a high or moderate risk of depression, then it flags to us. So it's unlikely that we would not address it, especially if that flags. People who do the pre-online assessment will definitely have a focused depression assessment on examination or during the history with the provider. And then this is just looking at, like, are there anything else going on? Is there anything acutely new, infection? We often see a lot of people present with changes in behavior due to UTIs. And so most patients, if they've had a high depression screen, or if it's something that's new, then that was addressed, where we ask about any other factors that could be taking place. We ask about cognitive function and dysfunction. We have a cognitive brain health team at our facility, and they address memory and mood. And so every single patient is asked about that, because we refer most of our patients to them. Functional status with Parkinson's is one of the top priorities as well. So that's addressed with every patient. And then medication history. And an examination and physical. And the examination is neural focused. So we do a UPDRS, which is the Unified Parkinson's Disease Rating Scale. So when I looked at my chart audit, what I'm really finding is that, you know, I have a very low number of people who are actually completing the standardized assessment tool prior to coming in to the clinic. And, you know, I know we don't need a formal scale to say, oh, I think what you're telling me is we need to treat that. But I think that I'm newer to the clinic. I started in January, and I can't tell you how many people I'm like, wow, I can't believe you haven't been on an antidepressant or you haven't been treated or seen cognitive health for this. So I just feel like it's very underdiagnosed, and I'm trying to change that in our clinic to see if we can get a better way of assessing for it.
Awesome. So now if you'll pull up your RAMPS worksheet.
Is that the measurement?
Yes.
Oh, I just had that up. What did I do with it? Hold on. Maybe it's up here. I'm sorry. But I've had like 100 things up today.
I understand. I have 2 desktop screens, and I think I don't know, they probably have 8 to 10 windows open each all the time.
I honestly just, I feel like what I am is maybe kind of confused on how to make these ramps. And I felt like, I don't know, I feel like I have a lot of things that I have to work on as far as when I turn in an assignment, I'm like, oh yeah, this makes sense. I understand what I'm going to do. And then I get feedback that tells me, oh yeah, but you're far away from this. And so I still don't know exactly how to fill this out. I feel like I just need some extra support.
Yeah, definitely. Well, that's good though, because that's kind of what this is for. It's why it's great that there's only 3 of us in this room today, or 3 students and me. So we have this opportunity to really go through, and for each of you, we'll really get to go through several measures. And we probably won't get to define the entire project for each person, but we'll get to go through this a lot so that you can have more clarity. So what I'd like to do is actually start kind of backwards. Instead of starting off with the A ramp, because the A and B ramps are their own special things that kind of require different tools to manage. Let's start off with the processes, and just tell me like what it is. The 2 processes are kind of the meat of the project, right? They're the 2 things that you first identified that you really want to do differently. And then let's just talk about them and see how we would frame them as measures.
So obviously one of the biggest process changes will be implementation of a standardized depression screen at the time of the office visit. It'll be a hard copy to, I guess, appeal to all the patients. And then the second process would be making sure that those results are then entered within the chart as a standardized form.
Okay, so yeah, I think making sure that every patient gets a hard copy is a really great idea. Are you thinking you would do this on the patients who have already completed the online assessment, or just the ones, or like everybody? You just walk in the door, you go ahead and get a new screen.
Yeah, I guess my initial thought was that it's going to be a new task with the medical assistant. They do medication history, they take their vitals, and then I'm going to have them give the PHQ-9, which shouldn't take too long.
No, it's a super easy assessment.
I initially thought it would be on everybody.
Okay. And what about people who come back multiple times? Would you just go ahead and do a PHQ-9 every time they come?
So that's where another thing that I'm like, I don't know if it's just easier for my project to say we screen at every visit. Some literature says at least annually, but it's just so hard because they say, some patients will see a different provider, they'll see a physician, and they'll see me. And I don't know, I know that if it's documented, I could tell if it was screened, but I think to start, I want to start everybody off on like a level field and give everybody the screen at every visit. Most of our patients on average come back every 3 months, but some are, 8 weeks later. So I would say that at least every 6 months that they are screened for depression, unless the unless they already are currently being treated for depression, then we might be able to do it annually, because then we just are managing their medication at that point.
Okay. Yeah, so anytime we're doing a screening project, we should talk for a second about the SBIRT model. Do you guys remember what that is? I think you've gotten this far in your course at this point. So actually, I don't know that for sure. I'll just tell you what it is. So SBIRT is a screening, brief intervention, and referral to treatment. So these kinds of projects are one of the most common projects. It's one of the most common formats that our projects end up following. So when you talk about screening everyone, I think that's perfect. It's ideal to just make it part of the process that you screen everybody. Will you always screen everyone? Will you always screen everyone at every visit? Those are things that you can kind of hash out along the way. This is not a perfect science. It's not something that we know for sure how the whole thing's going to work out right now. But I think it's a very logical place to start, that you screen everybody. So with screening everyone, then we need to figure out, you know, the rest of the model. So the screening is the first step, and then the next step is the brief intervention. So what are you going to do for patients that screen positive?
Right. And
So do you have a plan for that?
sorry. So the patients that screen positive, then I'd want a focused assessment or focused depression assessment with the provider. So then we would, you know, it would be more of a history screen. It would be talking with family, or if it's just the patient there, and getting a little bit more focused into asking questions related to depression. And then, you know, offering, depending on where they fall on the PHQ-9, offering treatment.
Okay. Does your facility already have a focused depression assessment that you like to use?
No, I guess not really. What we really do is, if someone scores high on the depression screen, it's really just more of a discussion that turns into, you know, I guess gathering further history related just to depression.
So what I would encourage you to do is to look for some kind of a shared decision-making tool or decision aid that is really focused on depression. Now, some of these things are going to be specific to Parkinson's and that kind of thing, but a lot of them really aren't. So you may have to look at depression decision aids and find some that you think are appropriate for your patients, or maybe even customize them. All the tools out there, unless they're copyrighted and you're not allowed to use them, you should be able to use and manipulate however you want to. So you would go through this, and that really becomes your patient engagement ramp. It becomes your B ramp that I guess I should have started with this. So the C ramp would be your screen everyone, nearly always. That's kind of how this works, is that like you have here, all patients are given the hard copy screening assessment. And then once they're positive, then you have to figure out what to do. So then that B ramp will usually be that patient engagement, where you sit down one-on-one with the patient, and a good decision aid, people are always worried that this is going to take forever, but a good decision aid or shared decision-making tool should speed up the process.
Okay.
It should be the 2 or 3 minute thing that you do.
The B ramp is the focused assessment tool.
Mm-hmm. But it shouldn't just be assessment. So when we talk about it as patient engagement, we really want the patient being engaged in their decision making. So when you look for shared decision making or focused assessment kind of things, ultimately you're going to want to get a sense of the patient's values, right? So you want to know, like, what are all the options for depression management? Well, it's medication and counseling and lifestyle interventions, and are they sleeping, and also the things that you mentioned that are specific to your patient population, like could they have a UTI or some other metabolic issue that's causing this? So you would want to have all of that onto one form of some kind, where you could go through and say, okay, we've checked off all of the metabolic things, it's not that. And then now the patient just has depression, and it's, you know, likely because this is a real hard thing to deal with. So here are the options, like these are the medications, these are the side effects, kind of go through the patient values, like because sometimes, you know, what medication you choose will really be dependent on what does this patient's depression present like, and what did they want.
Absolutely. And then, right. And
yeah.
I mean, a lot of them have anxiety, so then we're giving Lexapro. A lot of them have pain, so we're giving Cymbalta. So it does, you're right, it does.
Yeah.
So
yeah, that's awesome, actually. You know what, I used it was called a shared decision-making tool although it didn't get patient, so we won't really want these forms to get patient feedback, but I used one that was really good. I'm trying to remember the name of it. And I just kind of verbally got the patient feedback myself. You know what,
So
I
the
think
patient engagement is, will it be verbally, or will it be a handout that I give them on top of the screening that says, okay, so now.
it's good for it to be a piece of paper, but it doesn't have to be. Some people do use like a piece of paper for the provider that is like a motivational interviewing kind of thing.
Okay.
I like having it all written down though. And even if you're the
Yeah.
one doing the writing, like maybe you sit next to the patient, especially for a Parkinson's patient, maybe having them doing a ton of writing is hard. But you sit down next to them and you're sort of both looking at the paper and you're able to circle like, okay, you know, this question, let me look for a good shared decision-making tool. I know I've got a good example on my computer, and then I can, yeah.
Writing down what needs to be in that ramp. So when you do a test of change, what is the intervention like? I'm just writing what kind of falls under that category, but what will it actually state there?
Yeah, so it would say something like shared decision-making tool / brief intervention, and then maybe in parentheses, shared decision-making tool for all patients who screen positive for depression.
Okay.
All right, let me, I'm gonna try to screen share here as well.
So should I stop sharing mine?
You know what, it shared the wrong screen for me, so hold on, I'm gonna stop. There we go. Okay, do you guys see this decision box? Are you guys able to see my screen?
Sorry. I don't know why I can't see it. There. Oh yeah.
Okay, Sam and Sheena, are you seeing my screen? No, you're not seeing it? Okay, but Kelly, you are seeing it?
The prenatal screening?
Yes.
It says you are screen sharing, and then it has a 100,000 pregnant women. I see your
Oh,
screen.
yes. Okay, good. Okay, so this has nothing to do with depression, right? But this is a shared decision-making tool, and I just wanted you guys to kind of see the way it might work. And there are lots of these for depression and for lots of other topics. Okay, so as I scroll down, this just kind of gives some basic information. So it's talking about one of the hardest things we talk about in prenatal care, right? Which is like, how do you figure out what screening tool you want? And the reason I choose this one is because it's largely entirely dependent on patient preferences and patient beliefs and all kinds of things that we actually can't know about our patients in advance. And I feel like depression is similar to that. And actually most of our issues probably are. So this gives them some information to start with, like what are the risks, that kind of thing. And then it talks about what these conditions are, which depression is maybe a little bit easier to understand, but any depression screening or depression shared decision-making tool that you use will probably talk about depression, anxiety, contributing factors, all those kinds of things. So it'll have a section like this. But then this is the important part, my options. So a patient who has depression could take a depression medication. They could take an anxiety medication. They could use self-helps to try to get more family support, make sure they're getting more rest, eating well. They could see a counselor. And we know that the most effective thing would be for them to do cognitive behavioral therapy and to take medication. So all of that should be on there so that they understand that the best way to feel better is to do everything. But they can choose one of the options or not the others if they want to. And so this kind of goes through all the things that people might want to know about each option. And then what happens, you know, if you choose a certain option, what are the implications of that? And so this gets a little more complicated. You wouldn't have a page probably like this, or maybe you would. Maybe you'd have a page that would talk about effectiveness, you know, how likely is each thing to be effective? maybe.
Okay.
You would have to sort of decide that. The benefits and the harms of doing the thing or not doing the thing. So taking the medicine or not taking the medicine. And then what is your decision? This is kind of the important part. So after you've read all of this, after you've thought about it, what is your decision? Do you want to take the medicine or not take the medicine? And actually, in this case, you would probably have a much more complicated what is your decision, because you would be asking, do you want to do all the things? Do you want to do some of the things? Which things?
Right.
And then if you, or actually, you know what it would be? This question would be more like, do you want to do any treatment? Yes or no? And then if you wanted to do any treatment, what treatment would you choose? And then you, a lot of these screens, I like this one because I like the way it says importance of this concern, and people are supposed to circle like 5 stars or 1 star. And then considering my concerns and their importance, I choose. So it does not have to be this complicated. Not all of them are this complicated. But I like this one because it's just a good example of all the different things that can be on there. And then at the end, I love this part. Are you comfortable with your decision? Do you think it's the best choice for you? Do you have all the information you needed? Are you clear about what benefits and harms matter most? This little sure box, you could put on the end of any shared decision-making tool that you found, so that you made sure your patients really felt like they had all the information. And in a lot of cases, this can be your outcome measure. It doesn't have to be this exact box, but you can put something like this as your outcome on nearly any shared decision-making tool, because what you ultimately wanted was for the patient to have all the information and to make the best decision for them. Okay, I will stop screen sharing. And
So
we'll get back to you.
Forward to us, we can look at it.
Yeah, definitely. Let me send that really quickly.
And so the outcome measure, and this is just like the first ramp. So is this going to change every time we might have a different shared decision-making tool?
No, you probably won't. You'll probably stick with the same tool all the way through, although it's possible that you will, that you'll make changes to it, that you'll decide like this thing is too long or whatever.
So the outcome measure might be patient satisfaction with their decision or with understanding their.
Right. Yeah. So maybe your process is something like every patient receives the brief intervention, and then your outcome is something like greater than 90% feel confident in their decision or are happy with their decision or feel like they had all the knowledge they wanted. You really think about what's most important to you there. What is it that you're really going for in this?
Okay.
And then following on that model, we've done the screening, we've done the brief intervention, and then usually the D ramp is going to be something about referral or treatment or both.
Process 2.
Right. Yeah, and we sort of use that process 1 and process 2 as shorthand because we don't know what your processes will be, but you'll name those things when you have this sort of all nailed down, you'll name them something.
Okay, like PHQ-9.
Right.
Okay. And then process 2 would be referral to cognitive health or brain health team.
Right. Yeah, you might refer to the team, and then you want to make sure like sending a referral out into space is not all that helpful. So you'd probably want to do some kind of tracking to make sure that those patients got followed up appropriately, or how many of them actually made it to that to the referral. Because just sending the referral is kind of a weak ramp. But if you can show that you've got a really robust process in place, and people are not just getting referred out into cyberspace.
Could process 2 be appropriate intervention?
Yeah. Actually, that's an awesome one where you do we call it right care. It was on my list to talk about today anyway, so I'll talk about it for a second. So appropriate intervention, it's such a great idea because it basically means that the patient got whatever was appropriate to them. So maybe some patients do all of this, and it turns out that really maybe the most appropriate thing for them is just for them to get more sleep and rely on their family a little bit more, and you're going to follow them back up in a few weeks and make sure that they're really doing okay. But then for other patients, they're going to need the whole thing. They need referral to all the people. They need to follow up as regularly as they're supposed to, you know. So it becomes much more individualized and a little bit harder to track, but so much more important, right? Like, we don't want to just initiate a referral for everybody if they don't need it or
Right.
whatever.
Absolutely. Okay. And then, so that, I guess that makes sense to me. And so then the team, is that just our team that I'm working with?
Yeah, so then the team, and actually we'll talk about a team. Let's pull up one of the other projects, and then we'll kind of go over like what do the team interventions look like.
Okay.
So Sam or Sheena, would one of you like to present your patient tracer and gap and your whole project?
Should I stop sharing?
Yes. Very cute picture.
Ah, thanks. From years ago.
Okay.
So I'm on my cell phone. Sorry, I'm on my cell phone because for some reason it would not open on my computer. So do you want me to leave the call and come back so that maybe I can screen share?
You know what? Well, Sam, do you have your stuff to pull up?
Yeah.
Okay. Yeah. Sheena, why don't you try it real quick and see if you're able to go out and come back in and see if it works. And if it doesn't, then you know, you can read it to us and we'll survive.
Okay, thanks.
Do you want me to wait to get started until she's back in?
No, it'll take us a second to get it, to get going. So I bet she'll be back in a minute.
Okay. So let me. Okay. Can you see my?
Yes, I can see your screen.
Okay. So let's see. I don't know. I think I just closed my gap analysis. Where did it go? Sorry, this is my new computer and I'm still not very good at it. Okay.
That's funny. I have the Mommy's Toolkit open on my desktop too.
Yeah. I really like that toolkit. It's a really good toolkit, especially in our facility where we're not really doing a lot of pre-screening for moms who have identified at risk for NAS after delivery. So it's been a really good tool. Okay, so here is my. Do you want me to just start with the gap analysis?
Yeah, that sounds great.
Okay, so I identified we have actually, it was really hard to kind of narrow down the gaps that applied to my project specifically. So it was really, this was a really good tool, and I feel like I really learned a lot about the facility. But one of the biggest things that I found was that really weren't useful other than, you know, the basic initial prenatal care intake kind of forms that they fill out when they're coming to initiate their first prenatal care visit. So using them, I was able to find that there are some really nice screenings pre-clinic to kind of identify what level of care they require, what additional screening we can offer them, how frequently they should be visiting, and so on and so forth. So that was definitely the first gap. And down to was that we had a lack of access to a standardized screening tool. So everyone was either using their own screening tool that they'd kind of like printed off of the internet or something that they had left over from their clinical education. And then, you know, they were trying to do their own kind of screening in clinic. So standardizing that process was a definite identified need. And another big gap that Another big gap that I identified is that there really wasn't a lot of collaborative care amongst the different disciplines. So in our facility, we're the midwives and obstetricians are delivering on one floor, and then the NICU is on a different floor, and then postpartum's on yet a third floor. And moms who are on opiate replacement therapy and babies are actually separated immediately because postpartum actually won't do the initial observation. So there's a lot of obstacles to breastfeeding in this facility in particular. And then another gap that we found was that they're just still in the process of building out their HOPE program, which is the medical home that they're trying to create for opiate substitution therapy. So there really is a high utilization of triage and emergency services just because that medical home isn't really set in stone for these women yet. So kind of based on these particular, I'm gonna close this one. Based on those findings, the patient tracer I utilized was actually looking at different attitudes about partnering with patients and families, just because that seemed to be the biggest obstacle to supporting women who are breastfeeding, was just, are we honoring these women as accurate and adequate decision makers in terms of how they're dictating how their care goes? How are we identifying them? How are we addressing them? How are we giving report about them? So kind of looking a little bit more in depth at our attitudes towards these patients and their families was one of the priorities. And it was interesting. I completed this and I felt like I was at an advantage in regards to really looking at women as empowered to make decisions without regard for where they started, just because I just finished midwifery school. So that's kind of the mindset I was already in. But it was really interesting to see where other members of the team were in regards to this particular topic. And they just, you know, it was a pretty broad spectrum. Some felt like, you know, yes, we absolutely have to get them involved. Yes, they are empowered and able to make these healthcare decisions, and others were like, no, absolutely not. So that was an interesting thing that I identified definitely with the patient tracer assignment. And
especially in that big facility that you're in. Yeah. And I think, you know, you guys are seeing so many patients, and the midwives are, you know, very busy. It definitely, I think you're right, being fresh out of school, it gives you an advantage.
Definitely. And I think the biggest obstacle that I faced after doing the GAP assignment is that there are 17 of us. So with 17 midwives and 8 OBGYNs, it's really, really hard to have that kind of continuity of care. So being able to see, you know, well, was this patient screened? How was this patient screened? Who did the screening? What were the results? Unless it's really succinctly documented or they used some kind of preloaded tool, you know, sometimes you open the chart and it just says patient screened and some initials and that's it. So you really don't have the information that you need to know, you know, will this patient be compliant with care? Will they be a candidate for breastfeeding just based on their ability to maintain their visits and maintain their medications? There's some gaps that are created just because we're such a big practice.
So go ahead and pull up your measures worksheet and let's take a look at it.
Let me pull that one up. started off, I think it's this one. I just had it up on the screen. So I started this measures worksheet and I've changed it so many times just because I feel like I have a better understanding actually now that I've seen you kind of work with Kelly through the first part. But I don't know if I've made the right connections.
You know, there's a reason we spend a whole term making these plans, because they're that hard to make.
Okay. Okay, good. I feel a little bit better now. So the teamwork, I didn't know if that was supposed to be, I don't know. This is where I ended up with it because I just felt like this first plan was
definitely
the teamwork intervention.
So let me talk about teamwork for just a second. So I think the teamwork seems like an additional thing that we tacked on the project. It often when we're writing the whole thing, it feels separate and it feels like it's not that important. And it is the team that it is the ramp of all of them that is the least developed nearly every time. And now that I've been in this course, these courses a couple of terms, what I'm really seeing clearly is that is the ramp that holds it all together. If you don't have your team engaged, it just won't happen. You will have the best idea, and it will be fantastic, and no one will do it, and your project will flop. Because ultimately, you're asking people who are already busy and already working hard to do more work. So you've got to have a really good strategy for getting them to want to do that for free. And part of that is you're just going to rely on all the tools you have at your disposal. So absolutely, that test of change that you have there, the PDSA meeting and project initiation, pretty much every project is going to start off with some kind of kickoff meeting, right? Yeah. You have to tell everyone what the project is. They have to know what it is. You have to try to create excitement and engagement. This meeting is really important. You should plan it really well. So set a date for it now, maybe like the week before the project actually starts, something like that, maybe that week between terms or the very first week of the term.
Okay.
So plan it now, get it on the calendar, make sure, will your employer let you use a big room, or do you have, what is the best way for you to get people engaged and get them there? Maybe that would mean, having it at lunchtime and providing food, or I don't know, you're just gonna have to really, really think through it and figure out what can you do. Because from this point on, you have to really think like project managers, that you're responsible for getting the project accomplished, and it is not an easy feat. When it comes to invitations, you're going to want to make it really public. So you make a nice poster, something engaging, and you put them up everywhere, and you invite people personally, and you check in with them 24 hours in advance, and you say, hey, are you coming tomorrow? Remember, this is 2 o'clock, whatever, all of those things that really get people to show up, unless you have a mandate from your employer that says everyone has to be there. If there's already a meeting that happens, like a midwife provider meeting or something like that, you can try to piggyback on something like that, but you need to really talk to the people in charge in advance and make sure you have significant time and that you're given that time pretty early in the meeting, because the last 2 agenda items at most meetings just won't happen. And so you can't risk that happening. You can't risk, having 2 minutes to quickly explain your project while everyone walks out the door. So that's just the first ramp, right? That's just the first cycle, the first 2 weeks. This is kind of how you're kicking off. But then really every single week you need to be engaging your team in some way. So Sam, for you, I think, the whole team will be 17 midwives and 8 physicians.
Yep.
But maybe you start off implementing this smaller, and that's not a bad thing. That maybe you kind of take a look, and I haven't looked at what all of your plans are yet, but maybe you start off where you're going to implement just with just your own patients, or just a group of 2 or 3 of you that you think you can get really good engagement from. And then once you've got your forms worked out and the processes are all smooth, then you roll it out to the big group once the kinks are already worked out.
Okay.
And then as far as engagement, you can certainly do literature searches. You can, I mean, there is literature out there about patient or about team engagement. You won't find a lot of things. You may find some things in the traditional search engines, but you may just have better results going to Google. Every team, every business team, everything, they all have to find a way to motivate and engage people. So there's a lot of info out there. We've had students do, I need to come up with a list just to be able to show people. We've had people do the most creative and interesting things. In the last couple of weeks, I think prizes and competitions and that kind of stuff work well. We've had people come up with the craziest prizes, but if it works for your environment, it works, right? So yeah. I had a student once that had a kindergarten style sticker chart. And the big prize that people won for engagement was an X-rated coloring book. And let me tell you, the people in her facility fought for that. Like they were all over it. I've had other people do things with candies, with Hershey Kisses that have information about the project on the bottom side of it, or whatever. It doesn't even really matter, but this is the time to be creative and really put some time and effort and thought into keeping people interested in your project. Also, just a side note, when you sell your project because you believe it's important, right? You are selling this project because you believe depression screening matters. You believe neonatal abstinence and breastfeeding matters. Not because you are doing a DNP project and you really need people to help you. So when you go to someone and say, please, please, I need this for my project, or it's not going to work and I'm going to fail and I won't get my doctorate. Like, they have to like you a lot before they're willing to let that matter very much. They are much more likely to respect this project and to do what you're asking if you appeal to the important things. Like, hey, we really are supposed to be doing this, and it makes a big difference to our patients. We need to implement this project, and these are all the reasons why. And that creates lasting change, not this sort of, please do it just for me.
Yeah.
Okay, so let's glance really quickly at your process. Oh, one last thing about teamwork. You don't have to have all this figured out right now. Make as many plans as you can. Be thinking of what you want to do, but know that you're gonna keep coming up with things along the way. So if people are not engaged, you're gonna figure out a different method. You're gonna do more searching. So we're only figuring out the structure of the project and how we're gonna get started. You cannot possibly know what teamwork intervention you will do in week 3. You're just going to have to kind of see how it's going and think about it.
Okay.
Okay, so process 1, when I think about these, I always start off with process 1, then process 2, and then kind of go to patient engagement and teamwork. It just is easier for me to think about that way.
Okay. So process 1, I know where I need to be. It was just trying to phrase it in a way that wasn't so complex. And this is like the 15th time I've tried to go through this whole process 1. But process 1, the real goal is to make sure that everyone is screened adequately, placed in the right programs, placed in the right referral programs. They make it actually to the HOPE program because that's the facility's caveat and criteria right now to allow breastfeeding, just so that initial screening will actually have a huge impact on improving breastfeeding rates in the facility. So that's the screening aspect. So I don't know if that makes sense how I worded it, but that's my goal. And then process 2 was to just make sure that the referrals are making it out and making sure that they're getting through to lactation and doula services. Just because of the impact that improved support for NAS families has on not just breastfeeding rates, but just overall success rates with treatment just as a whole.
So as I'm reading this, well, first tell me about the shared decision-making tool.
Okay. So the shared decision-making tool I'm going to adapt. I found this patient engagement. I'll actually just click over to the site so you guys can see it. but it's called Ask Me 3, and it's 3 good questions for your health. And I don't necessarily like the questions that they came up with, just because it's like, what's my main problem? What do I need to do? And why is it important? I do like the idea of these questions though. So the first one I thought would be kind of like what am I focusing on for this 4 weeks or this 2 weeks? What do we have to do to make sure that I can make it to all of my appointments, that I have transportation, that I'm able to show up for my maternal fetal medicine screening, and then why is it important for me to do this? So I felt like it was a really good sit down, let's look at what our goals are, let's look at what has to happen for them to be accomplished, and let's understand why they were important. So I really liked this concept, and that's the tool I thought we could use for just patient engagement. It would just be easy. We didn't have to buy anything. So that was my patient engagement.
Yeah, I do really like the questions. I do think that it encourages engagement. So what I'm trying to figure out, I feel like your project is pretty huge right now, and we may have to kind of focus it down a little bit, which is, I mean, it's awesome to have a huge project and to have, you've got big things that need to happen here. For our purposes, I think you're probably going to have to focus one place or another, either like on the screening. So that screening is like screening for risk for substance abuse disorders in pregnancy, right?
Screening for risk of substance abuse disorders, and then screening for the biggest obstacle to breastfeeding in the facility is polysubstance abuse. So even if they're, opiate abusers and alcohol abusers, they're not candidates. Any marijuana use in the last 9-10 months is an automatic no from some of the neonatologists. So it's just making sure that we're identifying these things so that we're not building these women up for breastfeeding, and then all of a sudden they deliver and we're like, well, based on the screening we just did, you can't breastfeed.
Okay. So I'm just thinking about this. We could focus more. I think you're probably only going to be able to implement one screening, one kind of referral to treatment, okay, one brief intervention. So if we focus this more around breastfeeding, then it would be maybe on making sure that women are screened for all of this toward the end of pregnancy, like doing 3rd trimester screening for all the criteria that would leave them able to breastfeed. And that would be the only women able to breastfeed in these programs are the women who have already been referred to the HOPE program, right?
Yes.
Okay, so maybe like of the women in the HOPE program, somewhere at the end of pregnancy or middle, or really I guess it wouldn't matter, any time in pregnancy, making sure that you had screened them to see that they will be candidates to breastfeed according to all the rules that neonatology has. And maybe you will likely have to develop that screening tool yourself.
Okay.
I'm sure it doesn't exist.
Yeah.
So that would be kind of like a screen everyone. And then the patient engagement, I like what you've got there. I like the idea of that. For the women whose screening says that they can breastfeed, to me, the next logical step is to think the patient engagement would be something like, okay, according to our screening, you can breastfeed. Here is, all the information about breastfeeding. Do you want to breastfeed? Mm-hmm. At the same time, I really like those questions, and I like the idea of making it routine that you do this patient engagement at every visit. You talk about your goals. What do you think how would you document those 3 questions? Like, how do you feel like you'd be able to measure that providers were actually doing it at every visit?
Well, I might be too optimistic, I guess would be a good word, about the new EMR system, but we just went to Epic, so there's a lot of tracking that I've found that Epic is capable of. The issue that I've had with data collection right now is that we're on 3 different systems. We're using NextGen for prenatal care, and so we're like order entry and data tracking is really difficult, but it seems like once we're live with Epic, I'll have a lot more access to this data. And I was just kind of playing around with it. We can actually make an order set that says, ask me 3. It's like a little quick set charting. I can't remember what it's called, but you just kind of click it and it pulls into your prenatal care note. And you actually have to click it to accept it in. So, I mean, assuming that people aren't just clicking to say, you know, done, 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 I would be able to audit for them doing this kind of shared decision-making tool.
Okay.
Through their documentation.
So tell me a little bit more about the HOPE program. Like, is it a separate prenatal care system, or is it a program that, like, people are enrolled in HOPE, but they come to regular prenatal visits at your clinic?
Yeah, so they, you know, we had been referring people to, you know, another health system equivalent would be the Milagro program through UNM. So Loveless actually, you know, we have MFMs in-house, and we have a NICU, and we have prenatal care in-house because we're an enclosed system. So we just developed our own program, and that, you know, they receive prenatal care through us. The midwives still provide prenatal care. They do have to see the obstetrician once. MFM's in the building, so we work really closely with them, and then they're actually followed by the prenatal care providers, the maternal fetal medicine providers, the social worker, and then just a handful of our providers are certified to actually do the Subutex prescribing. So it's all enclosed.
Okay, yeah, that's really cool. Do all of the midwives take care of HOPE patients?
We are all able to and scheduled to take care of HOPE patients, but we don't manage, just because it's beyond us, we don't manage their Subutex or any of their actual opiate replacement therapy. We're primarily just doing the prenatal care.
Okay.
And then screening and referring.
Okay. So I think that this project can go one of 2 ways. You can either focus the entire project on early identification of women who should be in the program, referral to the program, shared decision-making to talk to them about the future, whether that's breastfeeding in the future or, you know, all of the things that, like, here are all the things about the program, and here's what you get from it. This is, you know, whatever. So shared decision-making is this a step you want to take in this pregnancy? Or I think you can focus this more on the end of the pregnancy for people who are already enrolled in the program. And you can find out, all of you who are already enrolled in the program, do you qualify to breastfeed, you know, at delivery? Do you want to breastfeed? Here are all the things, you know, whatever. Or I'm split on the ASME 3.
Yeah.
I think maybe you could do, I don't know. I kind of want to implement it in my own practice, because I like it. But anyway, you'll have to just think through that a lot and really come up with it. And then let's see. So what is, and then the process would be that sort of referral to lactation services, making sure that all of those things are in place.
Yes. Yeah, I realized as I was working on it, it was like there were all these things that had to happen before I could even focus on increasing breastfeeding rates. So I've seen over the last week or so that really the project has evolved to move kind of towards screening rather than actually implementing a breastfeeding intervention.
Yeah. Yeah, so I think focus it either on getting people into the HOPE program and know that in the long run that's going to increase breastfeeding rates for all these other reasons, or you know, and you can talk about that in your project, but then it would no longer be like the primary focus of the project. It wouldn't just be breastfeeding. It'd be about all the reasons that we want to take care of neonatal abstinence women. And then, or, you know, focus it more on the end and kind of keep it focused on breastfeeding. Since this project is so new, my suggestion would probably be to do the beginning, like get more women routed into the program, and then consider the breastfeeding focus to be like a next step that you guys are going to do in 6 months or a year. But I think that's entirely up to you. That's just sort of my instinct from listening to it.
Yeah, I've been pushing that way over the last few weeks. So I think that's probably where it'll end up. But then there was that, you know, that guilt about leaving my initial dreams behind.
Yeah, have you guys, I don't know if we've talked much about this, but I feel like one of the hardest things in a DMP project is following the evidence and following the needs of the site despite what you really want and what you're so passionate about. I know that for my own project, this was painful. I ended up in a very different place than I wanted to be. And I did something that I think is important, and I'm glad for it, but I have not forgotten my original idea, and I still intend to go back.
Yeah.
But I love that you're doing that you're thinking of the needs of the site, and, you know,
Yeah.
because that is hard. Okay, so all of that looks good. I feel like you've got, like, you know what it is that you have to work on. I think these projects are really hard because it takes so much thinking. You know, you just have to sort of walk around and think about this project every minute of the day for a month. And then you slowly start to figure out where all these ramps need to go. I think it's tempting for me to sort of pop in and in 5 minutes say, oh, do this and do that, do that. But remember that when I'm doing that, I haven't spent, 100 hours thinking about your project. So I'm giving you my best feeling at the moment, but ultimately it takes a lot more than the 15 or 20 minutes I spend thinking about your project to make this happen.
Yeah.
All right, cool. Well, I feel like you've got some, you're going to be able to kind of focus this from here.
Yeah.
I like where you're going with this.
Yeah. Awesome. Okay.
So a quick word about processes and outcomes and all of that stuff. Remember that your process measures are all sort of the thing you're doing. Like, we're going to screen all the women. We're going to do all the referrals. The outcomes are the thing you want to happen from the thing you're doing. So the outcome would be that who are supposed to be in the HOPE program get there, and all the patients who have depression are identified, or whatever. It's the thing you wanted to happen. But all of this has to sort of dovetail into the aim. And the aim really should encompass several of the ramps, and it should be the thing that you really wanted out of the whole project. It comes first, and sometimes the ramps come first, and sometimes you go back and forth and eventually get it all hammered out. But we do want each one of those ramps to really push forward into the aim. Tell us about your project.
All right. So I am doing the antibiotic stewardship program, and I started this because my hospital, they kind of highlighted it as an important thing that they wanted to see progress made on. And that started when the Missouri Hospital Association, which my hospital is a member of, they launched an initiative that's like an antibiotic stewardship program, and they launched that with federal funding and in conjunction with the Hospital Improvement Innovation Network, or HIN. So in the past, my hospital has done HIN projects, and it's really nice because they provide a lot of resources and upper level coordination, and there's obviously some federal funding behind it to kind of help get the ball rolling. So we started that at the hospital level last January, I want to say, so almost a year ago. And now they're kind of are at the planning to roll it out into the clinics phase. And so I've kind of been on board with it since the beginning, because I don't just work in the clinic, I also work in the hospital and the ER department. So kind of, been in from the ground stages of it. And so now it's kind of, identifying what are the target goals for the clinic, and where do we really need to focus. For the hospital, it was, I'm an old med-surg nurse, and so it was very easy for me to see, what the hospital goals were. I'm like, oh yeah, let's fix pneumonia. Let's fix catheter-associated urinary tract infections. I mean, that's my old stomping ground and what I'm comfortable with. When it comes to the clinic setting, it's kind of different. It's focusing on things like, acute bronchitis and upper respiratory infections and otitis media and stuff like that, antibiotics either shouldn't be used for or should be used significantly less for than they are. So that's kind of, where I came from on why did I pick this project, and kind of where is my focus been. When I did my gap analysis tool, just in all honesty, this term is just, it's mentally dizzying. I mean,
you to spend so much time just like so lost. Hopefully others are lost right there with me, and that I am not the village idiot in the course. So when I did my gap analysis tool, I was kind of like off in left field. So, I mean, I'll share it with you, and I swear there was some research and thought that went into it, but, you know, based on my feedback that I received, obviously not on point. So I've kind of revised and regrouped since then, and kind of gone from there. So I'll screen share it, or at least give it a shot. I have 2 monitors, so bear with me if it ends up on the wrong spot. Oh my gosh, what is that business? Okay, can you guys see that?
Yes.
Okay. Did you see 1,000 tiny monitors before that? Okay. I don't know how I did that. All right. So, you know, obviously first ramp is, you know, teamwork and kind of focusing on, you know, building your team and kind of going from there, and, you know, where are we lacking in management. And you know, one of the things I kind of identified in the teamwork phase is that our clinic management, unfortunately, our clinic managers are not paid very well at all. And so we have a high rate of turnover. We typically have a new clinic manager about every year. So that obviously creates some issues with implementing anything in the clinic. So I kind of made sure I included that in the gap analysis. But there's no, even though the hospital and, you know, therefore the clinics that they own have highlighted this as, you know, something that they really want to make a priority, there's no really clear cut and dry plan of like, how's it actually going to happen, and who's, you know, actually going to be in charge of it, and, you know, actually put forth some time and effort and energy and resources. So the other thing that I saw was like, we use GE centricity, which I don't know, you know, how familiar you guys are with that, but it is, worse. It's not the greatest EMR, and it's very hard to like extract data from, because so much of our documentation is done, you know, basically just freehand, free text. And so that is not something that you can, you know, extract. And so the pieces of data that I can really pull from our system are really limited to things that are, you know, like the actual diagnosis code or the actual like NDC behind the prescription that's sent electronically. Things like that, you know, can be pulled, but documentation of patients being provided education and things like that are, you know, they're going to be a manual audit to actually, you know, extract. It's not easy. So definitely a hurdle there. So then, you know, looking at the patient engagement piece, just kind of, there really isn't, you know, a huge effort to engage our patients in our antibiotic stewardship program. So far, really the only thing that has happened is, you know, our last clinic manager made up some signs and put them in the rooms that say, you know, hey, you might not be given an antibiotic today just because you don't need it, pretty much is what they say, and it's some really horrific grammar that I can't even look at. But, so that's kind of where we are on like the patient engagement side, is kind of ground zero. And then this is where I became truly lost in my original gap analysis. So we're going to skip over that. So I'm going to, wow, why does that keep happening? I'm going to stop screen sharing. Maybe it'll stop. Okay.
Why don't you pull up your RAMPS worksheet for us, and let's just take it.
Okay.
So I want to say it's totally normal to be lost.
Okay.
Definitely. However, the first draft is due really soon. You guys probably know what day it's due. I don't know what day it's due. But I know it's coming real soon. This is week 7,
Next
right?
weekend.
Yeah,
Yeah,
okay. I was
it's
gonna
due next
say,
weekend.
it's week 7. This is, I keep it in my head because it's like the hardest week of the term for both you and me. Because the second draft is really, you know, is easier. We have a foundation. We already know what we're building on, but the first draft is hard. So it's why this is so important. Like, I love these buzz sessions because I love having an opportunity to really touch base and say, okay, where are we headed, before you put a million hours into a giant paper that doesn't really go the right direction.
Thank you. Yeah, I would like to not spend a million hours going the wrong direction again.
It's only because I've done it that I can feel it. Okay, great. Oh, look, and you have it all filled out, so you may not be as lost as you think you are.
Okay, so I don't know how to scroll. It's okay. I'm guessing. Oh, wait, can you see it all now?
Oh yeah, perfect. That's exactly, that's just right. Okay, so let's start off with process 1. Let's see, provide delayed prescribing info based upon the CDC Get Smart campaign. I was gonna ask you if you're using the CDC Get Smart. So I love the CDC Get Smart, and it's fantastic because they already have pretty engaging posters. They already have all the things. You know, what you want patients to know is that antibiotics are not going to help them. And you want them to know that they're not good for them. You know, that it is harmful to our world, to our healthcare environment, to them specifically. And people will get that message if you tell them those things. I think the signs you were talking about that you guys already have up that are not engaging and that have weird grammar, a lot of the time patients take those things to mean like, we don't want to give you antibiotics because we don't care about you. And so you really need those signs to be like, no, we care about you so much that we're not going to give you antibiotics, and we're going to, you know, to do all these things that are harder but actually right. And that's a hard message to communicate. And the CDC doesn't do it perfectly, but they'll do it better than those signs will probably.
Yeah, they definitely have some really awesome handouts and, you know, posters to place in rooms and everything with, you know, nice graphics and stuff like that. I mean, they've done so much work already, like, you know, why not use it? So, so yeah, they have awesome handouts for delayed prescribing that, you know, give really clear directions for, you know, hey, if you're not better in, you know, it's got a blank, you know, you fill it out, how many days, you know, so if your symptoms haven't gone away in, you know, 3 days, 5 days or whatever, you know, you've been given a post-dated prescription for some antibiotics, you know, that you can get filled. What I did like about the CDC recommendations for the post-dated script was, you know, 1, to post-date it, you know, so that they've waited that 3 days or whatever, that they are probably already better. And 2, to make sure you put an early expiration date on it because, you know, I don't know nationwide pharmacy law, but I know in Missouri, if I write a script for amoxicillin, it's good for a year. So, you know, obviously that's insane. Like, you shouldn't be able to fill an amoxicillin script, you know, 11 months from now. Clearly that's not what I intended it for. So, so putting an earlier expiration date on it, you know, would be very helpful.
That's a great idea. I'm curious though, are you able to delay prescribing with your EMR?
I don't think so. So, you know, that's we can physically print scripts from our EMR, and then, you know, you could manually, you know, write a different expiration date on it. But, you know, I hesitate to add any like manual process because then it's just not going to get done, and it's not going to be, you know, data that I can capture because, you know, then I'd be relying on people to go back and, you know, longhand type in that they changed the date on the script. So the post dating I think would be easy, but changing the expiration date, I don't know if that's really feasible.
Is post dating possible on the ePrescribe?
I think it is.
Okay.
Because I think it is.
I've never tried it on mine, and I have not ever actually even thought about it. So I like this idea, but I would double check and make sure that that's a really possible thing, because then that's trackable. Okay. And you can tell everybody to print it out and you know, and change the date or whatever, or change the expiration date. But I think the thing you'd want to measure is really, are they getting post-dated prescriptions?
Right.
And I love that so much more than what I usually do, which is asking people to call back, you know, in 5 days if they're not better, and blah, blah, blah. And then they get stuck in triage loops and never
Yes.
actually get to me, and then they're angry, and you know.
Yeah. Yeah. And I work walk-in clinic. And so, there's no continuity of care. I'm going to cover Monday, Tuesday, Wednesday, and a totally different provider is going to cover, Thursday, Friday, Saturday, Sunday, or whatever. And so, that's the other thing with like asking people to call back is, they're not going to get me again. And so like having another provider kind of know what my original, track of thought was and not require them to come back in for another visit to get a prescription it's tough,
Yeah.
So,
okay. So tell me about your second process here.
So I want to include some kind of like algorithm clinical decision support just to like help guide, providers to stop prescribing for some of this stuff when they just don't meet criteria. So that's obviously going to be challenging and not, something that can really be, incorporated in the EMR in the short term. I'm not going to fix, the coding behind our piece of junk EMR. So that would be, something that would be, like a physical process. So I wasn't sure if, I could get like registration to, include that if patients present with certain symptoms or something, because, they do come into the room with a stack of paperwork typically anyway. And so, if they're there for an earache or a cough or, fever, wheezing, all the same typical upper respiratory symptoms that they all come in with, it'd be nice if they kind of had something that, even if it was like patient engagement driven, if they had started to fill out part of it and then, we kind of picked it up from there, would be kind of nice. But I don't know, I'm still kind of thinking. Any recommendations?
Yeah. So as I'm thinking about this, I don't know if something like this exists already, but actually I'm sure it does now that I think about it. It just would be like a right care algorithm, and you'd need one for upper respiratory symptoms, one for otitis media, all of, you'd need those algorithms. So your process would be, or ultimately, I guess, to skip to your outcome. Your outcome would be that, whatever, 70% or X% of patients received right care according to their diagnosis. And that means either receiving the antibiotic or not receiving the antibiotic based on what was clinically documented. And, you could even call it appropriate prescribing or something like that.
Okay. So, I mean, like finding the algorithm seems like the easy part. It's just like implementing it that seems like the challenge.
This is always true. Yes. So I think in your clinic setting, then what you'll need to figure out is where do we keep these algorithms? How do we make sure that people actually use them? How many providers do you have?
So the walk-in clinic is only myself and another provider. So,
Okay.
we're small. If I just focus this in the walk-in clinic, then, fairly easy. If I, want to try and focus it clinic-wide, it turns into a kind of a hot mess because we've got internal med and OB-GYNs and pediatrics and everything, and we're all in the same building.
So you start off with either just your patients or with just your patients and with just the walk-in clinic patients, and you'll have to decide which way you want to go with that. It may just depend on how much engagement you think you'll get from the other nurse practitioner. So the two of you, whether it's however you start out, then if things are going really smoothly and you guys have the processes down and this seems, like it's going awesome, then you could spread it to some of the other departments. Eventually, maybe you spread it everywhere. That would be ideal, right? If it's all going super smoothly. But sometimes not. Sometimes you do it just with your own patients and you realize this is cumbersome and clunky and no one else is going to do this. So let's change up the processes real quick, and you can do that 3 days in, 5 days in, 10 days in. You're making these little changes because you're looking at your data every couple of days, right? Every 2 days, maybe 3 days, you're looking at your data, you're figuring out if this is working, and you realize, man, if I can't even hit this at 100%, then how am I going to ask someone else to do it? So you change the process a little bit to make it easier or better or whatever.
Okay. So that's awesome. I would love to start it with, just me and kind of test it out myself and find the break and broken spots and tweak it and fix it. The other walk-in provider with me, so I talk to him, every time we kind of talk about, antibiotic use and antibiotic stewardship. It's like hitting my head on a brick wall. Everybody gets a Z-Pak from him kind of theory. So he's a very heavy antibiotic prescriber. And so it's kind of, I'll be swimming upstream to make any change there. But, I'd like to at least create some processes so that, the patients understand better, their end of things. And then, if they're less inclined to ask for antibiotics, then they're less inclined to get them even from a prescriber that's, really easy to get antibiotics from.
Right. And when you
Hopefully.
engage patients the right way, they often don't even want antibiotics when you explain it really the right way. And it depends on your population. But have you found a patient engagement tool that helps people to understand whether they need antibiotics or not, or what would make them need them?
I did, and I think it was part of the CDC Get Smart campaign, and it
Perfect.
was just kind of like explaining, these symptoms are typically viral, and, just because your mucus has changed color does not mean that you have pneumonia, that kind of stuff. So lots
Okay.
of really good patient education tools.
And then just make sure that somewhere in all those forms that you're also getting a sense of the patient's values, like that they are responding back to you, that it's not just you providing education to them, but that it's a two-way street here. Because those patient engagement tools really need to include, they need to have some patient input.
Okay. Yeah, I definitely want to see, what are the patient's expectations from the visit, because, reading journal articles and studies and everything, it kind of sounds like providers anticipate higher patients' request for antibiotics or, desire for antibiotics higher than patients' actual desire for antibiotics. So typically providers think a lot of patients are there seeking antibiotics when really they're not. They just want to know, am I going to be okay without them? Am I going to get sicker? Or what's going on here? So
Yeah, definitely.
it'd be very.
So with these, I don't know the CDC toolkit all that well, but I'd imagine that they have some processes kind of laid out. So I would really look through and see what kind of tools they have. I think between your process 1 and process 2, you need to be careful that they don't end up too similar.
Okay.
And also how many, like, what is your goal as far as delayed prescribing? That every patient would get it, or that appropriate patients, or whatever. And it's entirely possible that these two will work out just fine together, but just something to watch for, that you make sure you're measuring two real separate things.
Okay.
And then the teamwork, I think given your situation with the other nurse practitioner in your office, I think you'll have to really, you're going to just have to really pull out all the stops and make sure that that you give as much information as you can about, like, why this is really the best thing to do and why patients really are not as unhappy. I'm just guessing on his motives, but ultimately writing a prescription for something is way easier than explaining to somebody why you don't have to.
Yeah.
And so if you can make it
I
easy to explain why not, then that does help.
Yeah. I feel like it's so much harder to say no as a provider than it is to say yes. And, I feel like, working walk-in clinic, I do say no a lot, but yeah. I think it's appropriate.
It is. It is definitely harder though. So what about balancing measures? Do you guys have any balancing measures that you want to share? Does everyone know what balancing measures are? Do you get it?
No.
Not really?
No,
okay. I have a perfect analogy for balancing measures. This is not exactly the way the course describes them, but in my experience of implementing things in real life, I think that balancing measures are like the best idea ever. A balancing measure is basically, if you stop and imagine for a moment what the snarkiest nurse will be saying in the break room about your project when you are not there. And if you just imagine that for a few minutes, like what kinds of things people might complain about or what they might say, your balancing measure should be the way of proving that thing isn't happening. So she is going to say something like, this takes forever, and we are going to be working an extra hour every day just trying to do this extra paperwork. Or, let me think of all kinds of things like that. They're going to say this shared decision-making tool is too long. No one's ever going to fill it out. Patients hate it. They're going to say all of these things. And so then you are going to be able to say, oh, you know what? I actually track the average length of visits, and they're 1 minute longer than they were before we started this. So it looks like we're doing okay. Or whatever. You're going to be able to say, oh, look, you know, whatever it is that you think that people are going to complain about, oh, I'm tracking that thing. And you know what? That didn't happen. Like with antibiotic stewardship, the thing you will hear from this nurse practitioner is, oh, we're going to have all these people with, you know, inpatient now with bronchitis or pneumonia. You know, all these people are going to get really sick, and we're going to have community-acquired pneumonia rates go up. So you could consider tracking, like, what are the rates of people who actually end up with community-acquired pneumonia during this project? Oh, you know, 0? Okay. And then you'll be able to say,
Yeah.
like, hey, you know what, we looked at that. We actually didn't see an increase. And you're also validating, like, yeah, you know what, that was a really good concern. I'm really glad you thought of that. That was my biggest worry too. So that's why I decided to track it. It validates their concern without looking like you're just trying to be difficult or trying to shut down, you know, their concerns, which of course you are. But realistically,
Yeah, he flat out told me that. Yeah.
Yeah, exactly.
Yeah, he told me. Yeah, he told me antibiotic stewardship was going to kill people. I was like, okay, thank you. That's an awesome starting point. We'll go from there.
So you track those rates during, you know, during the project, and that way you're able to use that information. And then, of course, having some national data that shows that, you know, pneumonia rates don't actually go up. That would be helpful.
How do we rate? What do we write in that box? I guess assignment has been so vague, and that's where I'm getting docked all these points. I feel like I'm doing a good job, and then I get my patient tracer back and I get 11 points off because it's so vague. I meant all of the rubric stuff, but they wanted more reflection, and I never saw that anywhere, you know. So I'm frustrated with some of these assignments. And so as far as like the balancing box, like what do we write in there? Do we have to have?
Sure. Well, so let me just tell you about grades a little bit first. Like, we have grades in this course because they're required, and that's how universities give you know, points at the end of the year, give grades at the end of the year. But we have no desire to have grades in this course. I personally would love for this course to not have grades at all. And I find your grades, I think, almost completely irrelevant to the process. So you're never going to send this transcript anywhere. And I don't care if you get an A or a B in the class. I care only that your project is good. So by taking off points, and this is my personal philosophy, I have no idea if you're the person who's grading, well, I would bet that the person who's grading you feel similar. By taking off points, I'm only trying to say how much I think this needs to be changed. Like, hey, I think this is real important. I want you to pay attention to it. Because I don't have another good way of flagging like what's super important and what's just my opinion. And so I use the number of points I take off to kind of grab people's attention. But this transcript is going nowhere, and nearly everyone gets an A in this course anyway. So I'm not worried about what your grade is. I'm just worried about whether you end up with a project that is really as strong as you want it to be. And the project is ambiguous. The entire thing start to finish is ambiguous. It's actually what makes it doctoral work. Because you can't get a doctorate degree without it being an entire thing that you made up. And if we make any sort of rigid structure, somebody's fantastic project will not fit into it. And it happens all the time, actually, that we create structure and then someone is like, oh man, I had this great idea, but it doesn't fit at all. And then we realize, oh, you're right. Like, we actually just need to take the structure out and let people be creative and let them build these fantastic projects. And know that like your grade doesn't, if we give you a B on a project, it's not because we're saying you didn't do a good job. It's because we're saying, hey, pay attention to all this stuff that I said. So I think moving forward from there, like as far as the balancing measures, the way you're going to say them is just what you're tracking. So you're going to say, that you're going to, well, let me see if I've got some examples, actually. I bet I've got some on my computer here. Perfect.
Yeah, that's helpful. And I understand that it needs to be a little vague so we can have the room for flexibility, but Sheena, you're not the only one that feels lost. I'm like, I don't even know if this is what they're looking for. I'll submit it and see what happens. So I completely feel that way with this. Examples for assignments, I feel a lot better. But when there's not, I'm like, I don't know what they need. So I'm kind of guessing. I'm making my own thing. Like Sam, when you showed your patient tracer, like I don't even know how you knew to set it up that way. You know, like that's just not at all what I did. I don't know. I feel lost.
Well, the patient tracers all end up being totally different assignments.
I know. Yeah.
I've been so far off on so many things that like I tried to play it safe with the patient tracer, and I used like the IHI like time study tracer or whatever, and then I lost points because it didn't really apply to my project. And I'm like, I was just trying to meet the rubric. But yeah. And even some of the examples, I'm like, well, that doesn't meet the rubric, like that wouldn't pass. Like the diagram, the last thing we turned in, what was due yesterday.
Cause and effect one, right?
Yeah. Like on the rubric, it wanted like at least 4 like tools or guidelines or decision support aids or whatever to be included in it, and like that wasn't on the example at all. And I was like, I don't even know like how to include those, so I don't know. I gave it a go.
This is definitely not the kind of class where you can, look at the example and just kind of do something real similar. It really requires, you'll spend 2 hours thinking for every hour doing in this class, maybe 10 hours thinking for every hour doing. Because it just really requires that you come up with something that doesn't already exist, and that's really hard. I'm sorry, I thought I knew exactly where I was going to find a measures worksheet, and I'm finding all this other really cool stuff.
If, for example, I guess one thing that I had a question about is the like team engagement and the guidelines worksheet that we completed. It said link to team engagement toolkit, but what I'm hearing is that the team engagement can be like a meeting. How can you link it, and how can that be a tool? I guess I'm just confused.
So you had to link to a team engagement toolkit, right? But you don't have to use that toolkit.
Right. Okay.
You had to show us, like, that was a way of forcing people to actually do all the research, because what happened before we forced people to do all the research is that it seemed like a waste of time, so nobody did it. So people didn't actually look for those toolkits. Now, maybe your toolkit is perfect and you'll use it in your project, or maybe it's not, but it was a good example of a toolkit and you learned what one looks like, and you know how to structure your own now if you have to write your own. So the team engagement is not just a meeting, it's starting off with a meeting. It's a kickoff meeting, but then every week you're going to do something more or something different. So maybe you do huddles every day, and you follow all of the structure that is a team huddle. Or maybe you do a weekly meeting, but then you also put up charts with your run charts with all of your progress, so people are able to use that run chart and that feedback to motivate future behavior. You can do rewards, especially where you pit one group against another. I think individuals, that's a little dicey. You don't really want to call people out for being wrong, at least not publicly.
Are there like rules or guidelines? Are there like guidelines or whatever for like patient volume? Like, I worry that I won't have like enough patients like data wise to base all my changes on and stuff like that. So I just don't know what kind of numbers you guys are looking for.
Yeah, this at a very minimum, this needs to happen. Whatever it is that you're doing needs to happen 3 or 4 times a week. But I'd imagine that in a walk-in clinic, you're probably having a couple a day, right?
Yeah.
That's good.
Okay. I just didn't know if that was enough, or like, if, it needed to be like 20 a week or something crazy. I just didn't know.
Yeah. So ideally, go ahead.
3 a week. I'm sorry, I couldn't hear what you said.
Yeah, at least 3 to 5 a week, something like that. But some part of your project should really apply to all of your patients. So, there's almost always a part, like a screen everyone kind of thing. And if you're screening everyone, then everyone's being engaged, but not everyone's going to screen positive for depression. We do have sometimes, I think, a problem with depression projects specifically where no one screens positive for 2 weeks. then none of your other ramps can even be activated because no one's screened positive. This is stressful when it happens. But then you just find a way to expand. So depression projects would either be expanded into, well, we're going to screen more people so that we're going to screen all the providers' patients, or something like that. Or it could be expanded into, hey, you don't technically meet the criteria for depression, but you've got, you scored this many points on the PHQ-9 or whatever. And so we're going to talk about lifestyle interventions and ways to optimally care for yourself. Those kinds of things.
Okay.
Okay, so I'm just going to some of my students that that usually do the best work and kind of pulling up different or just interesting projects or whatever and pulling up their stuff. And so I didn't love the balancing measure that I just found. I mean, it wasn't bad, but it wasn't the best example of what I was thinking of.
So the first draft that's due next week, that's just the measurement form. There's nothing that goes with that. Is that right? Or is that, am I wrong?
I thought it was the draft of the entire, let me pull up PC 730.
I guess I haven't even looked yet. I'm just focused on the ones due today. I can look
Me
at
too,
that,
don't feel bad.
Yeah, so that charter draft, so this entire course is built on the charter. The charter is the thing that you will come out of this entire course with.
Got it.
And so if you don't have a functional charter, you don't get out of this course. And so week 7, it is the charter draft, August 19th, 11:55 p.m. And so that will be the draft of the entire charter as a whole. So it includes your measures and all of that, but the
Yeah,
it's all of
I
it.
see that. Never mind. So my form, if I'm going to be implementing this to only my patients to start, and then there's 4 providers, 6 people on the team, and so if I'm implementing it just to my patients to begin, does it still go under team? Team engagement, that I'm going to be explaining to them the project and
Right, because yes, because the team is still, and you can define your own team however you want to. So your team right now might be you and your medical assistant and your receptionist or whatever. But generally that kickoff meeting, I recommend telling everyone. Go ahead and do the big, the greater team, and then say, hey, here's the whole project. This is where I'm at. I'm going to start off next week implementing it with just my patients so I can work out the kinks, and then we'll see where we go from there. But if it's going well, then, and you're kind of gauging that whole, how excited is the team about this? And can you get them, as much involvement as you can get from them now, the better, because you're building your coalition of support now. If you find that everyone hates your idea right now and they don't like what you're doing at all, then it'll be that much harder for you to build support later. So you can try to, right now, get them involved a little bit and build them into the process. Okay, so the balancing measures that I'm looking at right now from these other students, one of them wrote her, and actually I don't have her full measure, I just have the operational definition. But so it was her goal was 80%, and the operational definition is the number of staff reporting satisfied or very satisfied over the number of staff who responded to a survey. So basically she's doing her balancing measure is like a team satisfaction survey. So does this project make people so annoyed that they do not like the team, they do not think it is working? And so, and actually we haven't talked about operational definitions. Do you guys understand those, what those are?
No.
Not so much? Okay. So the thing that happens when you come in and you do this project and you write your measures and all that stuff, and this all sounds super good, it's kind of like right when you turn in an assignment, you're like, yeah, I got this, I know what's going on. And then you show up on the first day of implementation and you kind of feel like, what are we doing here? What's supposed to happen? I don't even know. Because it all feels so fluid and ambiguous. It's kind of like sand through your fingers. It's hard to catch. And so, so that operational definition, it allows you to create an Excel spreadsheet that says, like, I'm going to track the number of this thing, the number of times this happens, and I'm going to create a fraction between the number of times this happens and the total number of patients I saw today, or whatever. And you use that Excel spreadsheet to keep all your data for all of your patient charts that you're reviewing every 3 days. And it automatically calculates into these percentages, and you know what your progress looks like then. And you know what numbers to put on your run charts because you have this all nailed down to such a totally clear picture. So that might be, so in Kelly's case with the depression screening, you're going to screen every patient who walks in the door, right? And so the first thing you're going to track is the number of patients who received the screening. So you're going to say that 20 people walked through my door today, 20 patients came in, and 18 out of 20 received their screening. And so if today, if you're, calculating, if you're writing in your process measure for today on that ramp, then you're going to say that, like, you're going to do it by numerator and denominator. So your numerator is the number of patients who received the screening, or you could say complete the screening or fill out the screen. Like, how specific do you want to be? Do you want to count the number of people who received the piece of paper or the number of people who filled it out? Or I don't care, you decide, but real specific. Think through every one of those details. And then you're going to put that over the number of people who came in for an appointment today, or the number of people who came in for an appointment over the last 2 days, if that's how the time frame that you're doing your, your stuff on. When you spread this to another provider, then how are you going to change that? You're going to put a little annotation box on your run chart, and you're going to say, now it is the number of patients who received the screening over the number of patients who came into the clinic that day, or the number of patients who saw this provider or that provider today, or the number of patients who are eligible to be screened, because you are the only 2 providers in the project right now. And so the only people eligible to be screened are the ones in your project. And when you make it really clear like that with the numerator and the denominator, then you know exactly what you're looking for. So with your staff engagement, a lot of the time the staff engagement outcome ends up being some kind of survey, right? Maybe you're surveying, there's actually a team engagement survey that a lot of students use. So, so what if the team engagement survey, let me think, I don't really know what the scoring looks like on it, I don't remember, but let's say that there's a potential for 10 points. And your team, when you average all the scores among the team for that week, you get 8 out of 10 points. So you could report that as a mean score instead of as a numerator denominator. And that would probably be clearer, right? If you just put in one number, like our composite team score for this week is 8. Or, whatever, as you watch that, as everyone hates the project and tracks down to 4 or something, or as everyone loves the project and by the end of it, you've got this composite team score of 10 because everyone's totally engaged and into it.
So do you anticipate that we would have to do a team engagement survey? Like, how is this going for you every week? I feel like what if they have the same answers?
And often they do. Usually we get a team, you're doing some kind of team process every week. You're doing something to engage them every week. And then you're going to be tracking your outcomes more like every 2 weeks or so. So you're not usually doing a weekly survey. And you don't have to use the survey as a way of tracking the outcome. You can do other outcomes, but the survey is one that I see done regularly, where people feel like, okay, this makes sense to me. I can track how well my team is liking this.
Thank you.
Okay, so so operational definition. Does somebody want to pop up their measures really quickly, and let's just operationalize one measure together?
Like my worksheet again?
Yes. Yeah, I should have done this when we were talking about them earlier, and I wasn't even thinking about it. Okay, so let's look at the process one. So your process measure was provide greater than 20% of patients with included diagnosis code documentation of delayed prescribing info with access to a post-dated or e-scribe available on callback to the clinic after an agreed upon day. Okay, so what you're wanting to do here is to track. So
I'm going to start with my total number of patients that are included. So based on like diagnosis code and then by provider. So ones that I saw that have a diagnosis code of otitis media or acute bronchitis or cough or, you know, any of those that end up kind of lumped into it. Like I'm going to start with that, right?
Right, so that'll be the denominator. That's your total patient population for this project. And then your numerator would be the number of people who receive this delayed prescribing in some form. So one of the things that numerator denominator that operationalizing really helps you to see is when your process and your outcome are really the same thing, just worded differently. So take a look at your outcome. So the percentage of patients
so it's
with
gonna be the
documented,
same thing.
Right, it'll end up being the same thing. So what you need to figure out then is what is the process for getting, like, what is it that you really want? You really want people to be getting this delayed prescribing. So your outcome is probably fine because that's what you want people to be getting. So then what is your process for how to get them this delayed prescribing?
Well, like I think
tricky.
I'd probably keep my process at like 20% or less. Actually, I probably have that worded backwards because I really don't want to offer a ton of delayed prescribing to patients that really shouldn't need antibiotics anyway. And then my outcome measure should really be like how many like delayed prescriptions actually have to be given or are actually filled. So that way it factors into like total number of antibiotics given for these conditions.
Oh, that's interesting. Yeah. How hard is it to figure out how many are actually filled?
It wouldn't be that hard. There's only 3 pharmacies in town. And like,
well, that's super cool, actually. That's a really interesting idea. I like that. So yeah, play with that a little bit. But you can see how easy it is to get confused in these measures because just a little bit of rewording can feel like a totally different thing while being measured the exact same way. Yeah, so then when we look at the patient engagement go ahead.
Okay. Yeah, this feels like a throwback to care plans in nursing school, honestly, but
you know what though? I never got care plans. Like I never actually found them to be useful in any form. And maybe I'm the only one. I don't know.
No, you're not alone.
This thing is foundational. Like if you don't have this, you get there on your project day and you're like, well, I don't know what we're doing here. Someone tell me.
All right. Okay, so my patient engagement, so I want to provide shared decision-making tool to greater than 80% of my total patients that I see, and then measure how many I actually gave. Is that just saying the same thing again or not?
It's close, and you certainly can. Like what you would essentially be measuring is the number of people who received the shared decision-making tool in your process, and then the number of people who completed it as your outcome. What will happen is that those two numbers will track really closely together, and I don't know that they will tell you a lot of things differently from one another. So they are different, but when you think about it for a while, you may find that it's not really what you wanted to track. So what you could track as your outcome measure would be something that's on that patient engagement tool. Like what percentage of patients after completing the engagement tool wanted to receive an antibiotic today.
Okay.
Or something like that. Like and that actually may end up being really useful information as you're talking to other providers where you can say only 50% of people who had one of these diagnoses even wanted an antibiotic once we gave them the truth or whatever. Or maybe it's not, it's up to you. Like you read through the engagement tools, you think about what you want, what information you want from the patient on there. And then you can write these tools. So you add a question to the bottom, or maybe that sure block of questions at the bottom that I had on the example. Maybe you say like, after completing the engagement tool, like what, 70% of patients will feel sure about their decision to take antibiotics or not, or something like that.
Okay. Yeah, and I mean, even like I hear like the same like consistent themes like from patients from like why they're there is like, I worried I'd get worse. I worried this would develop, into pneumonia. I was worried I would have to miss work. I was worried it was Friday and I'd get worse over the weekend and I'd have to go to the ER. Like, I mean, you just hear consistent themes from patient after patient. So, I mean, it shouldn't be that hard to kind of find that stuff to put on the patient engagement tool.
Yeah, definitely.
And then measure part of it. Okay, that makes sense.
Cool. Okay. I'm just looking at my list, seeing if there was anything else that we needed to talk about. Well, so I just want you guys all to know, like, when you look at the points on this first draft, like, we expect that the first drafts are going to need some revision. That's why we put 2 drafts in the course, because it's so important that the final be perfect, and that 90% isn't good enough. Like 90% on your final paper will just mean that 10% of things get you derailed next term. And so we don't want that. Like, I just want it needs to be perfect. And so the feedback you'll get on this draft will be, there'll be a lot. There'll be a lot to talk about probably. Most people need to make significant restructuring after the first draft. But that's why it's built in there. And that's why we're only on week 7, and there are lots of weeks left in this course to do all of that rethinking and rewriting. So put a lot into it now, give it your best shot, but just know that that we expect this to be an ongoing dialogue. And these projects are actually really just this hard to write. So I don't want you to feel discouraged, like why are you having trouble with this? No, I mean, you're having trouble with this because it's this hard. It's still hard when I write one now, and I've done a bunch of them. And I still feel like I'll get derailed, on things. Are there any questions that you think I can help with right now? Does anyone feel better for having done this today?
Mm-hmm.
Okay.
I feel less alone. I mean, and now I'm bracing myself for the bloodletting that's going to be my grade on this charter draft.
Yeah. Me too.
So definitely, I mean, get help from your peers, talk amongst yourselves about what's working and what isn't. But then you can, we're always here. Send a note to your continuity faculty person and just say, hey, I want to talk about this. Like, this is what I have actually, it wouldn't be a bad idea if you're not sure about your measures once you're kind of getting your measures written. You can always send them to your faculty person and say, hey, take a look at these. Like, do you feel like I'm on the right track here?
One thing that I had a question about when you were talking about that we review the chart maybe every few days, and we're like the run chart progress and putting things into an Excel spreadsheet. I mean, is that all, like, we make all of those sheets and spreadsheets ourselves, and do we have any direction on, I guess I wouldn't even know where to start with, like, I don't know.
So it'll be similar to the idea that you did with your chart audit. But yes, we do have I think there is a sample that we just kind of borrowed from one of the students in a previous class that we can show you as far as like Excel spreadsheets and what does it look like, and how do you track your data. Let me see if I have it right here.
But that will be given to us at the end of this term or before we start the next implementation?
So in the past, every student just created it on their own.
Okay.
But I think, I know that we sent one out, and I don't remember.
Okay, I'll go back and look.
Okay. But basically, it's an Excel spreadsheet that just says, like, here are all the 12 things that I'm tracking. And, and then it allows you a fast way of saying, like, patient chart. And then you're going to put, like, yes, no, yes, yes, 12.7,
Kind of like the way I did my patient tracer. I guess I'm just wondering, so there's nothing standardized in that, or it's kind of how we want to track our own measurements.
I think because it ends up being so different for each project that it's a little bit hard, but we do have some examples. And so if you don't find those or don't get those, just email me and I'll find it and send it to you. Okay. I can't remember what I saved it on my computer under right now. So the things that I searched were not it. But yeah, I'm sorry. I think I was going to say something else about that and I lost it. All right. Well, let us know, or let me know if you have other questions or whatever. You can always send your continuity person, your continuity faculty member, a set of your ramps and just ask for help or whatever. I don't want you to feel like you're completely alone. It is normal to feel like you're sort of, I don't know, painfully walking uphill or something. But you shouldn't feel like you're the only one doing it. All right, guys, have a good Saturday. And I'm excited about your projects. I think you all have really good ideas. So I can't wait to see where you go with them.
Thanks for your help.
All right,
Thank you
bye,
so much.
guys. You're welcome.